There are many things that are looking quite sort of fantastic in combination approaches to the treatment of melanoma. And again, if we go back to the model of some patients have what we described as a T-cell infiltrate, an inflamed tumor microenvironment, and some don't, we can now start to think about rational models for developing combinations. So in those models where there are already T-cells, we need to do things to further augment those T-cells. And those can be tumor microenvironmental factors like oncolytic viruses, metabolism, things like IDO inhibitors, other immune checkpoints we could all add in combination. But that's in contrast to those patients who don't have a T-cell infiltrate or a tumor, an inflamed tumor microenvironment. In those patients, we need to focus on how do we get the T-cells into the tumor so that the PD-1 antibody can work. Because until the T-cells are in the tumor, the PD-1 antibody is not going to do anything. And perhaps things we could do there are like radiation combinations or vaccine combinations or other approaches that would drive T-cells into the tumor. And actually, in thinking about the plenary, it dovetails with this because if we looked from the phase 1 trial, the combination of ipilimumab and nivolumab seems to overcome the lack of PD-L1, suggesting that the CTLA-4 antibody, ipilimumab, may be able to drive the T-cells into the tumor where the PD-1 that can help them work better. So we're starting to split these into two camps of how to think about drug development, and to me that's the most exciting because we can maximize then the benefit for patients based on their immunological status, not just their molecular status, BRAF, NRAS, c-KIT that we have been doing for the past 5 years or so.